Friday of each month, we typically have a program that's sort of OMC oriented. Next month we'll have a presentation from our former Chief Physician Officer, Josh Jones, will be here to talk to us about his early experience with telepsychiatry in the Providence system. And then we have the third Friday of every month a Swedish topic and presentation. This morning we're really privileged to have Eric Lewis return to us, and he usually comes once a year or so and gives us an update on the sort of work that the Washington Hospital Association is doing. And so we welcome Eric. It's always great to have him here. And with that, Eric can go ahead and get started, and there'll probably be, I would bet, some time for a few questions after his talk. So welcome back, Eric.
Thanks, Dr. Fisher. It's great to be here. Good morning, everybody. I've actually almost been at WSHA for 4 years, if you can believe that. And I will say I really enjoyed my 22 years at Olympic Medical Center. It was great to work with the medical staff and the board and our employees and community, really achieving OMC's goals, mission, and vision. So it was great, and I do miss the organization, and I actually, through my work at the Hospital Association, I work with OMC and try to help OMC as much as I can. So I just want to briefly say something about WSHA. We are fortunate to represent all 113 hospitals in Washington State, which is a bit rare. Most hospital associations do not have all hospitals as members. And on the left there, first, urban versus rural, it's about an even split. There's 48 rural hospitals and 45 urban hospitals. And another thing that's unique about Washington State is the urban hospitals and the rural hospitals actually work together. And it made COVID go a lot better with transfers. And both rurals and urbans recognize that each are important in the state's delivery system. And then type of hospitals, there's 41 public hospital districts like Olympic Medical Center, and 52 nonprofit hospitals, and 13 for-profit hospitals, primarily behavioral health hospitals. There we go. Uh-oh, user error. Okay. What I first want to talk about is the hospital's financial challenges across the state. And I think everyone, the post-pandemic fallout, the federal support being gone, labor shortages, inflation, it's been really challenging. And the federal government really supported hospitals well in 2020, 2021, but that support really disappeared in 22. And nationally, hospitals really had negative margins especially in 22 and in 23. And in particular, I think rural hospitals faced huge challenges. And the rural hospitals facing the biggest challenges are the small critical access hospitals, and then the large prospective payment system hospitals in rural areas like Olympic Medical Center. And back in 2021, if you had told me what was going to happen, I wouldn't have believed you as far as hospital finances. 85% of hospitals across the state lost money in 2023, which is pretty staggering. I've never seen this many hospitals lose this much money. And combined in 22-23, Washington State hospitals lost $2.85 billion from operations and had over $3 billion of net losses. And I'm not exactly sure what $1 billion is, but 3 of them is a lot of money. And these losses are staggering. What's interesting, or what's I guess a fact, is Washington State hospitals have lost more money than hospitals across the country. A lot of hospitals lost money, but Washington State hospitals did worse than average. And there's a number of reasons. One is low Medicaid reimbursement. The state of Washington had not given a rate increase to large urban hospitals on Medicaid for over 20 years, which, if you can imagine paying for the cost of labor and supplies in 2023 based on what you got paid in 2003. So that Medicaid losses are huge, and I'll talk more about that because there's going to be a large Medicaid reimbursement increase here in 2024. Hasn't happened yet, but we're getting closer. I think more patients get stuck in hospitals in Washington State than other states. We have maybe the post acute care delivery system is less available and less capable than some states. So people get stuck in hospitals, and I'll talk more about that. We have higher wages than other states, and we have lower commercial and Medicare rates than other states. So the losses here have been particularly intense.
Eric, you mentioned that 85% of the hospitals lost money. Are there any little niche learning observations about the 15% that didn't lose money?
Yeah, that's a good question. I think the hospitals that made money tended to be the large critical access hospitals that got paid cost from Medicare, Medicaid. So I think the big niche is, do you have adequate Medicare, Medicaid reimbursement, and how much commercial you have? I think hospitals with very high commercial and adequate Medicare, Medicaid reimbursement made money, but I think it was, because hospitals, typically their costs, they're pretty much price takers. The free market, you got to buy labor and supplies and pharmaceuticals. But what Medicare or Medicaid pays you and how much commercial you have seem to be the magic formula for the 15% that made money. Of course, Olympic Medical Center has one of the highest government payers, I think at 84%, something like that. So that's extra challenging. And now I just want to briefly go over the WSHA surveys all of our members, and this is the calendar year 23-22 income statement. I'll just briefly go over it. It represents 96% of occupied beds across the state. And in total operating revenue in 23 actually went up 11%. Remember back in 22, we had that first quarter of 22, we had that wave of COVID Omicron that really suppressed revenues. But, and wages and benefits went up $2.6 billion, about 16%. And about 9% of that is wage increases, and 7% of that is more employees. Traveler costs did go down to $1.4 billion, which was a 24% decrease. But $1.4 billion for travelers is a staggering number. I mean, before the pandemic, that might have been $500 million. So it's really increased. Operating expenses overall went up 9%. I think the key takeaway from this slide is the net operating loss. In 2023, hospitals across the state lost $1.7 billion, minus 5%, and then in 22 they lost $2.1 billion, minus 7%. So things got a little bit better, but not that dramatic. Historically, this has been positive 3 to 5%. I've never seen across the board losses like this. Certainly not for 2 years in a row. And I'll talk a little bit about the reasons for this at a later slide and what's happening to fix this situation. And I think there's reason for some optimism, but it's definitely very challenging. And then the net non-operating gain loss from investments, as we looked at our retirement accounts, we realized 22 was a very big loss. So the loss was $932 million. In 23, it came back positive $907 million. COVID relief and FEMA funding actually went up in 23, was about $500 million. I think it's all gone now in 24. There won't be any additional funding. But there's several large systems that had huge COVID relief related to 2020 and 2021. They brought it into income in 23. But the net loss, the bottom line for hospitals in 23 was minus 1%, $332 million. Now there should be positive 3 to 5%. And the main reason hospitals have to make a small margin is they got to pay principal on their debt, and they need to invest in capital. And you can see total employed FTEs went up to almost 123,000 in 23. That's about a 8,000 employee increase, 7%. So hospitals are finally able to hire more people, but still don't have enough. Oh man, I keep doing that. There we go. Next slide is days cash on hand, and this is for all hospitals. And days cash on hand is how much cash do you have? How many days could the hospital continue to operate if no cash came in? And typically a hospital, should be about 3 months, maybe 90 days cash on hand. A really strong hospital might be at 6 months, 180 days cash on hand. And starting on the right, you can see hospitals with over 200 days went down 50%. Between 121 and 200 days of cash, which is a strong cash position, went down 27%. Most hospitals in the state are between 75 and 120 days. There are 13 hospitals between 0 and 75 days of cash. There are 4 hospitals right now operating with less than 11 days of cash. So they're literally this week collecting money to make next week's payroll.
How many? 11 hospitals?
4.
4.
Hospitals with less than 11 days of cash.
You tell it's not us.
It's not OMC. But I think the $3 billion of losses resulted in $3 billion of less cash being in hospitals' checking accounts and savings accounts. This just represents the losses in 23. If I had the 21 days cash on hand, you would see 2 years of big decreases, and it's staggering. And it's fortunate that hospitals had reserves, because boy did they need it after the pandemic. And the reason for these financial losses, and I'm sure we all kind of know these, inflation really was at a 40-year high. We really had modest inflation for a long time. And, headline inflation of 9%. Certainly labor, supplies, and medications went up in cost. And fixed government reimbursement really did not keep pace. And that's been a huge part of the losses. Certainly the workforce shortages, agency and traveler costs, plus hospitals have lost revenue by not having the workforce they need to take care of the patients. Inadequate Medicare, Medicaid, and other government reimbursement, huge. They just did not participate in the inflation. If costs went up 10% and Medicare gave you 3%, that is a big challenge. And across the state, the complex discharge patients have been quite a challenge. People getting stuck in hospitals for 3, 6, 12 months is actually common. And it makes no sense to live in a hospital. You don't need to be there for acute care reasons. Being in a hospital is not a healthy place to be. It's not designed for living. But there's no safe place to discharge these patients. So hospitals just, they stay there. And in Seattle, on any given day, approximately 10% of acute care beds are occupied by people that don't need to be there. Think about the cost of that. It's staggering. And this is a big problem. And from a state's perspective, these people are staying there for free. So it actually saves the state money. We had a state senator say, what's the problem here? But I think it's really bad for patients, and it's not good for the employees and hospitalists trying to run a hospital to have all these people there that don't need to be there. Some of them can be disruptive and quite challenging to take care of. And I know OMC has had some of these, and it's just very challenging. My next slide, I'll talk about health insurance payers. Charity laws, there's lots of charity in Washington State. When people carry $5,000 deductibles, have modest income, hospitals wind up providing financial assistance per state law. And, an increased government regulation and particularly rural OB services are under a lot of pressure from financial losses, workforce shortages, and just getting medical malpractice insurance. So all these challenges are there. I'll talk a little bit about some of the good things happening to make these better in 2024 at a later slide. And then what's really emerged post-pandemic is insurance companies, health insurance companies, business practices are really compounding the financial issues hospitals face. It's never been easy to get paid by insurance companies, but they've taken it to a new level post-pandemic. One, slow paying, challenging pre-authorization requirements. I think denials is the biggest thing. A lot of insurance companies are denying 15 to 20% of claims. They have to be reworked, and about 95% of those wind up getting paid. But they deny. We have hospitals that, insurance payer will deny every claim over 15%, over $15,000. They just deny it. It winds up taking 6 to 9 months to collect the money. So it's a cash flow issue. You eventually get paid, but these denials are quite burdensome. And these issues are in commercial insurance. There's 5 Medicaid managed care organizations. And now Medicare Advantage is really starting the denial game. And I talked to Mike Lynn at Jefferson, and one of these Medicare Advantage companies was denying 57% of their claims. And they had Jefferson Hospital as their network for hospital, and then OMC Physicians was their network for physicians. So everything was out of network, everything was being denied. It's a mess. And some of these insurance companies are using AI to just go in and deny thousands and thousands of claims. And it's quite a challenge. This is a new area that WSHA is starting to work in. We have working with our members on, but it's hard to believe what's happening. I do believe there will be, hopefully we can get this fixed for hospitals, because it's hard to get paid right now. And then on advocacy, WSHA is one of the big things we do is advocacy with our members. In Olympia, it was a 60-day session this year that ended March 7th. These are the issues that we talked about a lot, and the biggest one was complex discharge patients. Significant new funding over the last 2 years has happened, about $500 million of more funding for these patients, everything from dementia to brain trauma, but it's still more investments are needed, and then guardianship's a huge issue. People get stuck in hospitals. They're not capable of making decisions for themselves, so they stay there until a guardian gets appointed. Rural OB was a big issue. We tried to get a lot more funding for rural OB, and I think we got about $3.5 million of grants. Not near enough. But the biggest issue, I think, in rural OB is just a adequately trained workforce. Having the workforce. If you deliver 60 babies a year, think about having a competent workforce to do that. Very, very difficult. And now we passed a bill allowing EMTs to work in rural hospitals. So these EMTs can work in emergency departments. We passed more behavioral health coverage and treatment options. So that's moving forward slowly. I think the biggest thing we did was stop what we consider bad bills for hospitals. There was a merger and affiliations bill that would have made it very difficult for hospitals to affiliate or work with other organizations, perhaps do a merger. And we were able to stop that. There was a contract negotiations bill that would have prevented, kind of like Olympic Medical Center, you typically contract for both the hospital and the physician group, right? Because you want it. But it would have prevented hospitals from doing that. An insurance company could say, I just want to contract with your medical group. I don't want to contract with the hospital, which would have created huge problems. And really, we wanted to make sure hospitals, especially public hospitals with publicly elected boards, could make their own decisions about how they're going to serve their community and who they're going to partner with. And there was a lot of controls. Basically, the state attorney general would have controlled what happened, which we were able to defeat. So the good thing about advocacy, I mean, Washington, D.C., this will be surprising to everybody, but fairly dysfunctional right now. Main thing we do in D.C. is really stop bad ideas, which are cuts in Medicare primarily. And there were big proposed cuts in Medicare, particularly for off-campus hospital-based services, like, Olympic Medical Center has their SQUIM campus. There were big proposals to make more cuts. They were kind of bipartisan. Both Republicans and Democrats thought site neutral was a good idea. Site neutral is quite a bit. I think it's a terrible idea, but we were able to stop those bills. But I will say that rural health care, both in DC and Olympia, is bipartisan. Both parties want a functioning, viable rural delivery system. So there's reasons for optimism, but it's been real challenging the last few years. And now I'm going to talk a little bit about the solutions or things that are happening that are helping hospitals' financial challenges. And the biggest thing is there's a big Medicaid reimbursement increase coming. And I started at WSHA in June of 2020. And the first day of work, I was given this assignment to work on Medicaid reimbursement. And we're almost there on getting a big Medicaid rate increase. And it's been a long process. The state has historically not given, for the last 20 years, the state has not given urban hospitals any increase. And that's how they balance their books. If one of your big expenditures doesn't go up, that really helps. But we have passed something called the Medicaid Safety Net Assessment Program. We call it SNAP. It's going to be implemented in 2024 as soon as CMS approves it. In 2023, the legislature passed a bill. It passed the House 92-3 and passed the Senate 49-0.
This is state.
This is state.
Yeah.
So it was a huge effort. I worked on it for years. We ultimately got bipartisan support, so it passed at the state level. We still need to get CMS approval. We've been working on it for the last 6 months, and we're very close to getting it. I think at the end of February, I decided I wasn't going to shave until CMS approved it. As you can see, CMS has not approved it yet.
Why would CMS hold it back? It's not their money, right? It's state money?
No, it's federal money.
It's federal money.
It's 100% federal money.
But it's governed by the states.
Yeah, Medicaid, of course, is a state program that's funded in Washington State. It's 1/3 state money and 2/3 federal money.
Okay.
So the way this assessment works is there's 98 hospitals in the program, and the hospitals agreed to tax themselves. So the hospitals, Olympic Medical Center is a little different, but I'll talk about Olympic, but most of the hospitals are going to pay a tax to the state. The tax totals $900 million. And then the state takes some of that and keeps it for complex to discharge patients. The rest of it goes and gets a federal match. and the federal government sends $2 billion back to the state of Washington. Now the state will take that $2 billion and give it to hospitals. So the $1.1 billion is the net benefit. Hospitals will get paid $2 billion more for Medicaid services, but they paid $900 million tax. So their net benefit is $1.1 billion. This is a huge increase. This is about, I think it's about a 33% increase in what you get paid for Medicaid. So it'll really help hospitals across the state. Now Olympic Medical Center is with 8 other public hospital districts. We call it the large PhD hospital SNAP program. And rather than paying a tax or an assessment, OMC is going to, because you're a governmental entity, is going to use an intergovernment transfer. And then state will get the match and then send it all back. It's actually a little bit better because they wind up a little higher reimbursement. And I think Olympic Medical Center is going to get about $10 million in 2024 from this program on increased Medicaid reimbursement. So it will help a lot. It's much needed. Olympic Medical Center is still going to get paid below cost for Medicaid. So no one's getting rich here. Even this $1.1 billion, it brings hospitals up to about 82% of cost, which is about where Medicare is. So it brings Medicaid up to Medicare, but it's not a good business model to spend $1 and get 82 cents. But it's better than getting 50 cents, right? So this has been a big heavy lift for WSHA and our members. But I think the 1.1 billion is really going to help. It'll actually be 1.2 billion next year. This is ongoing. So this will probably deal with a little more than half of the financial problems, maybe half of the financial problems. It won't solve them, but I think it'll give hospitals a much better chance with adequate Medicaid reimbursement. We're also implementing this new software called the AHA Vitality Payer Scorecard. Statewide, hospitals are signing up for this. It will track denials, time to pay, claims. Basically takes all the bills hospitals send and all the remittance advices that insurance companies send hospitals, and we're able to get statewide averages. So for the first time, we'll know exactly what Premera Regents denial rates are, how long they're taking to pay, and we can track it real time every month. It is really cool. It will give us a chance to do advocacy at the federal level for like Medicare Advantage. At the state level, we'll work with the Office of Insurance Commissioner and perhaps propose legislation. But it'll shine a bright light on health insurance payer business practices around paying claims.
Well, for these delays, patients are then holding the bag until they pay 9 months later, and so this would be publicly available information.
Yeah, a great point.
That'll be huge.
A great point, Mark. I mean, the patient gets caught in the middle. So let's say you're sick, you have some care, suddenly you get a letter saying your care's been denied. That's pretty stressful, especially if there's like $50,000 bill. Eventually it gets paid, but that's 9 months later, 6 months later. Waiting for pre-authorizations, waiting for claims to get paid, denials. It's very stressful on patients, and I think some patients blame hospitals, but it's really the insurance companies denying, I think, legitimate claims. And one thing we're finding, hospitals will get pre-authorizations, and then they'll do the service, they'll send the bill, it'll still get denied, which is hard to understand, but it happens thousands of times across the state.
Like a double negative or
Yeah, insurance companies taking denials to a whole new level. We pre-authorized it, but we're going to deny it because we can. Complex to discharge patients. There's been about $500 million investments here. It's still not enough, but I think more post-acute care options, better payment rates for these providers, but patients still get stuck in hospitals. The good news is, I think, patient volumes are growing, inflation is slowing, reimbursement is slowly catching up. operations are improving. I'm seeing hospitals slowly getting better, but it's very slow. Some public hospital districts are considering increasing tax levies, and some have voted it, and voters are actually passing these. Workforce shortages are slowly decreasing. We did pass some legislation, and more RNs are being trained. There's been some movement at the federal level to train more physicians, but it's been slow. And people are starting to re-enter the workforce. All that COVID money is gone, so people need to go get jobs. And hospitals are really looking at what services they provide. They can provide. One hospital closed their OB unit, and I know other hospitals are considering it. Most hospitals have closed their skilled nursing services. They just can't afford the losses.
Eric, speaking of closing, in the last 2 years, how many Washington State hospitals have closed and how many nationally have closed?
And in Washington State, the number's 0. But like I said, there's 4 hospitals with less than 11 days of cash. So if one of them closed in the next 12 months, I would not be surprised. Nationally, it's probably, I don't know the exact number, but it's probably been about 100 hospitals, particularly in states that did not expand Medicaid, like in Texas, Alabama, Georgia. The rural hospitals, the uninsured rates have gone way through the roof, and they just aren't viable anymore. And Washington State has relatively low, I think we're like 48th or 49th in acute care beds that are that hospital beds per 1,000. Other states have a lot more, maybe a lot more hospitals. We don't have, I think the hospitals we have are the hospitals we need. We haven't really added a lot of beds over the last few decades, but our population has gone up by 1 million people, so there's pretty high occupancy in Washington State.
A little shout out to Vicki and others with the second to the last item there, and the rather incredible program that the UMC Foundation has created for scholarships for nursing students.
Yeah, that's fantastic. I've been reading that and supporting that, but it's definitely the type of things that are happening statewide and have to happen. You can't just wait for the workforce to show up anymore. I know OMC, trains medical assistants, RNs involved with known in their residency program for family practice. We really have to grow the workforce, particularly people that want to live in Clallam County. If we can get them trained up, they can have a great career, which helps them, the community, the patients. Oops, I keep doing that. Now I'm going to shift gears a little bit from finances to the Affordable Care Act. And when I was working here, this got passed in, there was maybe 15 months of negotiations, and it got passed in March of 2010. And then it really started 1/1/2014. That's when the expansion happened on Medicaid and the health exchanges. And that's over 10 years ago. And I think the ACA, it's been quite a road, but I think it's been successful, particularly on access. And I think it's hard to remember before the Affordable Care Act, but before the Affordable Care Act, insurance companies had something called pre-existing conditions, and they used it a lot. It was very difficult on patients. There's 100 million Americans with pre-existing conditions, and I think the ACA kind of getting rid of that concept that health insurance could underwrite you as you applied. If you needed health care, then they could deny you, right? And then you became uninsured. And uninsured rates were 14-15% when this went into place, which is staggering. That's a lot of your population not covered. And then young adult coverage, young adults up to 26 can stay on their parents' health insurance. I know both of Jake and Christina were on my insurance at various times, and it really helps. So I think there was a lot of access. I think what's unique about the ACA compared to most government programs is actually it was fully paid for. It didn't add to the deficit. I think the challenge with it is half of it was funded by reduced Medicare increases. Like rather than getting a 3% increase, there was a minus 0.5% for what they called productivity increases. So they'd give you a 2.5% increase. And doesn't sound like much. Rather than getting 3, you get 2.5%. But after a decade of that, OMC is probably getting paid 4 or 5% less for Medicare, which is a lot of money if it's over 60% of your business. So I think OMC's one of the challenges is, of course, Medicare reimbursement, and the ACA paid for the Medicaid expansion, paid for the marketplace insurance half through Medicare cuts, and the industry agreed to that because we couldn't handle 15% uninsured. But that is an ongoing challenge, and certainly OMC getting adequate Medicare reimbursement is probably the top of the list. I know Daryl and his team are working on that. And so far, 40 hospitals have expanded Medicaid. It's, Texas, Florida, and some southern states have not expanded Medicaid, which is paid for. The expansion lives are 90% federal dollars and 10% state dollars. But that's been interesting to watch. Washington State, of course, expanded on beginning of 2014, right away. The number of people covered, I think, is pretty impressive. Nationally, it's about 45 million residents, about 20.5 million in the marketplace plans, and 24.5 million in Medicaid expansion. And then some states have done kind of a basic health plan, which is kind of Medicaid expansion. They just don't want to call it Medicaid expansion. But 45 million people is quite dramatic. This is in 2024. Washington State, almost 1 million people are covered. 272 million through the Washington Path Health Plan Finder, and over 700,000 on Medicaid, which is about 13% of our population. So that's pretty dramatic. I think here in Clallam County, I was trying to find the exact number, couldn't find it, but I think in Clallam County, it's around 8,000 to 10,000 people are covered either by Medicaid expansion or the health plan finder. So if you can imagine 8,000 or 10,000 uninsured people, more than there are now.
Has charity care costs gone down then?
They have. Back in 2013, I remember charity costs kind of were going up, and it hit over $10 million in 2013, and it went way down to about 2 million, and then I left OMC, so I don't know if you guys know where it's at, but I think it's 2 to 3 million.
Yeah, probably about that. It really significantly went down once we had the Medicaid expansion.
Yeah, it was which is good. I mean, you accept less Medicare reimbursement, you're hoping you have less charity, and it actually worked. The uninsured rates up there in the US, in 2013 was 14.5% uninsured. That's gone down to 8% in 2022. And if the last 10 states expanded Medicaid, I think that would go down to about 6%. A lot of people qualify for Medicaid expansion, states have not expanded. In Washington, it's gone from 14% down to 6%. Here in Clallam County, it's gone from 15.5% down to 4.5%. So I think that's been dramatic, and I think particularly our children in our state, pretty much almost every child can get coverage some way or the other. And that's, I think, awesome. Access is, having insurance and then having a physician and healthcare facilities that will take care of you is an important piece. But I think the Affordable Care Act has definitely increased access, slowed cost increases, I think, done some things around quality and innovation, but it's been quite a ride. Any questions or comments on the Affordable Care Act? It's a big part of my career here at Olympic Medical Center, along with the meaningful use of a certified system. Remember that, Epic? In 2013, we went live. I remember being in this room in 2013 and went live, and like there was a balloon. I don't know. Mark was here.
May 5th.
What?
Night.
Yeah, it was about 4. Yeah, it was about 4 and 5 in the morning.
Yeah.
I can say there are some hospitals that stayed on Meditech. They're still on Meditech today, and I can tell you they're suffering. Although as hard as the Epic install was and the journey, those rural hospitals on Epic, I've really seen, on Epic, I think it helps with recruiting, it helps connecting, it's really helped with the revenue cycle. But the rural hospitals on Meditech are really struggling right now. I mean, I think, I think some rural hospitals could fail because of their IT strategy. If you're on Meditech right now, I think it's a big challenge. So Olympic Medical Center was able to take those meaningfully used dollars and do the conversion, which was, I know it wasn't easy, but believe me, if we were on Meditech today, OMC would be in a much worse position.
And I read Forks is switching to Epic.
Yeah, Forks is heading to Epic. The original plan was for Forks, OMC, and Jefferson all to go Epic at the same time. And finally it's happening. Forks is going Epic. Forks is going with Epic with multi-care. But that's going live, I think, in June, something like that. That'll be great. I think Forks will be better off on Epic than Meditech. And they've got a good plan to implement that. My last slide is about quality. This is a busy, crazy slide. I won't go over all of it, but I just wanted to say that WSHA and our members really work together on patient safety and quality programs quite a bit. Dr. Scott Kennedy, Scott, you've been a leader in this for over a decade, probably a couple of decades. But
Hard to believe.
yeah, but Scott's been a leader. He's well respected statewide. And I think what's happened here in Washington, which doesn't happen in most states, is all the hospitals have agreed to work together on patient safety. So if one hospital develops a best practice, they share it with everybody. And I think this cooperation has led to safer hospitals. The big things we're working on, equity, resiliency for our workers, and safety culture. Trying to come out post-pandemic, trying to make things stronger. On the left there, we're helping to implement laws. There's a big staffing law. House Bill 1272 relates to collecting sexual orientation, disability, and gender information from every patient. That is hard. That's not easy. We also have a lot of grants and contracts, primarily around OB and opioids. Working on ED processes and diagnostic excellence with our hospitals. And then kind of in the middle, there's a greenish thing, it says SNAP. And the Medicaid Safety Net Assessment Program that we're implementing this year, we're very close to implementing. If you see me clean shaven, you'll know that we have implemented. And hospitals are getting their money.
Tanya, you're looking styling.
Yeah, I'm just hoping for Christmas I'm not looking like Santa Claus, because that would be that'd be very bad. That means CMS hasn't approved it. But there are some quality measures related to the SNAP program. C-sections, hospitals are going to try to reduce the percentage of C-sections. Readmissions, and then substance use disorder follow-up after ED visits in 30 days. And then mental health follow-up after inpatient stays in 30 days. So those are the quality measures we're going to work on. But lots of work happening around safety and quality, and it's kind of getting fired back up after the pandemic, which really threw a monkey wrench in a lot of things. And I'm done. That's I got time for questions. You can probably stop sharing. I don't know if there are any questions, but I think that's a brief summary of hospital financial situation, and I can talk about advocacy a lot if you want, and the Affordable Care Act. There may be some comments or questions on that.
I have a question about innovative payment models and value-based purchasing, and like what other kinds of models is Washington State considering besides fee-for-service?
Yeah, great question. I think Washington State is probably behind other states in innovative payment models. You know, California heavily into capitation and managed care. In Oregon, same thing, a lot more capitation, a lot more innovative. I think in Washington State, we in the 90s, there was a big movement into capitation and alternative payment models. And I remember Dr. Gasek and I were working at Stevens Healthcare, and we got into Stevens Health Network where we took capitation for Medicare, Medicaid, and commercial lives. It all blew up in the 90s. It ended with tens of millions of dollars of losses. And I think there's been a lot of resistance in Washington State to alternative payment models. Mainly because I think some of what the federal government or commercial insurers or state around Medicaid, they're trying to get immediate savings. Hospitals aren't interested in getting paid less, at least, you know, right away. So, but I think right now, most of the urban systems have integrated delivery systems where they're taking risk on commercial lives, some risk on Medicaid lives, and some risk on Medicare Advantage. So I think there's some going on. A lot of rural hospitals are working on accountable care organizations. Medicare has a program where critical access hospitals can participate in that, where you manage your population health, but there's not very much or no downside, there's upside. But I would say Washington's behind in innovative payment models. I think the federal government is going to move from voluntary to required, because I think that's probably the only way many hospitals are going to make that leap. But I think fee-for-service has hung on probably longer than we ever imagined. Certainly in 2010 when the ACA passed, we thought, oh my gosh, fee-for-service is going away. Well, fee-for-service is alive and well right now. But I do think ultimately hospitals will be more at risk for global budgets and outcomes and less fee-for-service. Commercial companies, quite frankly, in Washington State have been hesitant to give up that. They like being insurance companies. Because if hospitals are taking all the risk, why do you need insurance companies, right? So Regents and Premier really haven't gone there. But I think Medicaid and Medicare ultimately will head towards more global budgets, global payments per patient. Maybe not full capitation, but more like shared risk. But I think the pandemic moved that back, and the hospitals' losses the last 2 years hospitals have not been interested in going to alternative payment arrangements. That's a long answer that it's still in process. I mean, I think it's coming, but I think it'll be Medicare telling hospitals, here's how we're going to do this, which hopefully will give hospitals some upside. And I think OMC is more efficient than most hospitals. Hopefully that could mean higher reimbursement for OMC and less reimbursement for hospitals with high utilization. But again, there's hospitals in Florida that might not like a model like that.
Dade County.
Yeah.
So Eric,
Yeah.
I get a feeling that a lot of, depending on the specialty, reimbursement rates obviously like some are vastly different. Behavioral health, pediatrics reimburses very low.
Yeah.
And I feel like when we're in a situation where we're not getting good reimbursement, that it's those service lines that are the most vulnerable. I mean, Tufts Children's Hospital closed their doors.
Yeah.
You talked about an OB unit that's closed their doors in Washington State. So I'm just kind of curious, like, do you get a feeling in WSHA as far as, instead of looking at hospitals, but looking at specific service lines that are most vulnerable in Washington State?
Yeah, it's a great question. I think you're exactly right. I think we're starting to focus on rural OB, the mental health delivery system, and substance use disorder delivery system. Both are way underfunded. I think we're also looking at, Medicaid really pays low for professional services. So WSMA and WSHA are working together to try to fix that. It's going to be, there was a bill in 2024, it didn't pass, but we're going to we'll hopefully get it through in 2025. And I remember I talked about the Medicaid Safety Net Assessment Program, where hospitals pay an assessment, get paid additional money. We're going to try to do something similar to that for professional services. But the proposal was to tax insurance companies, and the state give that to physicians. Insurance companies didn't like that, believe it or not. So it ran into some opposition. But I think Medicaid rates are really too low for professionals services. Same with Medicare. But I think WSHA and WSMA work closely together. We actually meet, and our advocacy teams work a lot together. And I think a lot of WSHA's members employ a lot of physicians. So I think we have shared interest in getting adequate professional reimbursement. It's one of the things we tried to do in rural OB was get a add-on for rural OB providers, but that didn't happen.
So just to sort of clarify, is it that it's not so much that pediatric or primary care is poorly reimbursed, it's that the population they serve is poorly paid for, right? I mean, isn't it?
Well,
I mean, it's slightly different. I mean, isn't it more that?
Well, I think it's both. I mean, I think the cost of doing good primary care is very expensive,
Right.
and what Medicare, Medicaid, and even commercial pay doesn't quite cover it.
Right.
But I do think, in pediatrics, Medicaid patients need more services. So you wind up with a tougher payer mix. Primary care can be a lot of Medicare, a lot of Medicaid. So I think the system, fee-for-service system, pays for procedures really well, but for physician time and managing populations, like the work that you guys have to do, it really pays poorly. It's MRIs do really well. You really have to, as a physician or RN, spend a lot of time providing care. It's poorly reimbursed, and you tend to wind up with more government and more uninsured. Require more resources.
But do you see hospitals cutting service lines though to make the bottom line? I mean,
Well, I think hospitals will cut service lines to avoid bankruptcy.
Yeah.
I mean, bottom line is if you have 11 days of cash,
right.
you're going to make some decisions you don't want to make. And I think, a hospital had to shut down their skilled nursing unit. And I think hospitals will make some tough decisions, and they may not expand services they need. Like they may need more primary care or more pediatric care, but there's no money to expand them. So I think that's happening in a big way, and I think there are services at risk because ultimately, hospitals are highly motivated not to go bankrupt.
Bill Kintner, I think, has a question. Go ahead, Bill.
Thanks, Mark. Morning, Eric.
I know.
Do you have any comments about the consolidation of hospitals in the state that have led to a preponderance of the Catholic systems? I know there's been quite a bit of attention in the popular press about that, but do you think that matters from WSHA's standpoint or from the management of healthcare standpoint? I just wonder what your comments are about that in general.
Yeah, I mean, we have three big Catholic systems in Washington that probably represent, 45%, maybe 50% of occupied beds. And I think in general, hospital consolidation has happened due to economics. It's very difficult to be a standalone hospital. And a lot of the consolidations have happened due to financial challenges. I think the Catholic systems have great missions. They take care of a lot of people. I think that this tension in Washington State is around abortion services and death with dignity. And Catholic systems don't provide those. I mean, typically abortion is not done in hospitals. It's done outpatient wise. And I think there's a lot of tension there. Also, death with dignity, I think allowing physicians to discuss with patients. So there's definitely some tension, particularly in Olympia. I think that's 99.9%. That's not what the services that hospitals provide, but we're focusing on the 0.1% or less. But I think the amount of there's the largest provider of Medicaid services and charity care in the state is Swedish Providence. They have a great mission, take care of a lot of great patients, but there's just some tension there, particularly since Roe versus Wade got overturned. I think that tension has been heightened. So, but I think the Catholic systems do a great job for their communities, but it's partly, I talked about those merger and acquisition bills. There was some of that is the reaction to not wanting the Catholic systems to get bigger. But personally, I think they do a great job. And I think hospitals really are not the big providers of abortion services.
Eric, I have a comment and then a quick question. And Larry Gordon or Scott Kennedy may want to add to this. The complex discharge, which is something I've had some interest in for a long time. There are some subtleties to the complex discharge as I reflect back of one sort of current logjam that maybe isn't as apparent to, I know I sat in on a white paper presentation from the Bree Collaborative about this a few weeks ago.
Yeah.
And Darcy Jaffe from your group was one of the leads or presenters in that. And the complex discharge has gotten the spotlight, in my opinion, shined on it in recent years because of the social problems that have led to delays in discharges.
Yep.
That's the reason why complex discharge, in my opinion, has gotten so much attention lately. Well, complex medical or surgical discharges haven't gone away.
Yep.
Irrespective of the social issues. And one logjam is, and I don't know if you're aware of this or Darcy's aware of this, that MedCon at University of Washington has disappeared. And MedCon is a service that many inpatient hospitalists and actually outpatient providers have depended on for many years for subspecialty advice for complex patients who don't necessarily need transfer to an inpatient facility. And I think that, I only pick on MedCon because that's a poster child, I think, of what's happening in the Puget Sound area, is that a hospitalist who needs help with a complex infectious disease problem, who's in Port Angeles, who doesn't need to be moved to Swedish, can't talk to a doctor any longer about that problem. So you've got a patient who has a complex problem who could have an adverse outcome because we don't have access any longer to infectious disease, tertiary endocrinology, et cetera, et cetera. So that's a subtlety to the complex discharge problem that may not be recognized. And I wonder, I've thought about who to raise the flag up on this about. Is it WSHA? Is it the State Medical Association? Who is it that would have some traction from 100,000 feet to recognize that this is really a problem, particularly for rural hospitals who also are taking care of complex medical inpatients and outpatients?
Yeah. It's great point. I think both WSHA and WSMA have a role in this. And I think one thing that we're learning about this difficult to discharge or complex to discharge patients. We talk a lot about the 3 months or the 12-month patients, but it's all the real problem is patients get stuck for 2, 3, 4, 5 days. So how can we, so I think what you're speaking to, MedCom would help these patients quicker and perhaps get their treatment better, have better outcomes, and maybe get them out of the hospital sooner.
So,
Yeah.
But what they're going to in times of tough dollars is that all of those people that we used to go to, UW, Providence Swedish, and other systems like Franciscan Health now are all monetizing that because they're all developing telehealth programs where you would buy their services for every one of those things. So that's what they're all working on, and we will be marketed, we are starting to get marketed for those things.
Base rate, per use, or volume use, estimate rate.
Right.
Yeah, I think the labor shortages, not enough physicians, and then, they have too much to do, and then